everyone. My name is Professor Anderson Bamihaya of the Department of Anatomy, Faculty of Basic Medical Sciences, Bayero University, Kano. My lecture today is to do with the clinical anatomy of the abdomen. So if somebody as a patient comes to you and you are in the clinic, he comes to you with certain abdominal conditions or diseases, first and foremost, you have to ask that person to lie down on the couch or on the examination bed for you to make your inspections on the abdomen. After the inspection of the abdomen, you also have to palpate the abdomen, percuss the abdomen, or use your stethoscope to auscultate the abdomen. Then certain clinical anatomy of the abdomen includes the procedures that we do in the clinic. For example, when we want to treat certain intra-abdominal diseases or conditions, or if we want to make some diagnosis with regard to the abdomen. Certain clinical conditions that can also affect the abdomen include trauma. And this trauma includes the domestic trauma or accident, or maybe accident due to, when somebody is on the road. That is what we call road traffic accident. Again, infections, whether bacterial infections and viral infections and other diseases that can affect, the abdomen. So again, tumor. That tumor can be either a benign tumor or a malignant tumor. All these are kind of swellings or conditions that can affect, the abdomen. Again, inflammation, can affect the abdomen, like immune diseases, what we call the autoimmune diseases in the abdomen. Congenital abnormalities or anomalies, those one can also affect the abdomen. So if you discuss, the clinical anatomy of the abdomen based on this outline, obviously as a student you are going to excel in your examination. So as I was telling you before, if you want to discuss the abdominal clinical anatomy, when the patient comes to you in the clinic, you have to examine the abdomen. So for you to be able to make an examination of the abdomen or to inspect or palpate the abdomen, you need to know the topography of the abdominal cavity or the abdomen generally. You know that actually the liver, both the left and the right lobes of the liver are located on the upper part of the abdomen. The majority of the bulk of the liver is located on the right hypochondriac region, and the remaining portion is located on the left hypochondrial region, this area. Similarly, the stomach and the other part of the stomach, like the pyloric antrum and the small intestine, the stomach and the pyloric antrum are also located in the upper part of the abdomen, while the small intestine that includes both the, the duodenum and the jejunum and ileum, they are mainly placed in the center of the abdomen. Something like the colon, that is the ascending colon, is located on the right lumbar region, and the transverse colon is located just above the umbilical region, and the descending colon is located on the right, left lumbar region. And so the sigmoid colon as well as the rectum, they are located far down below the abdominal cavity. So other important organs in the abdomen includes the pancreas, and the pancreas is located immediately below the duodenum, approximately approximately in the middle of the abdomen, and also the spleen is located just on the superior side of the stomach. That means the spleen is located on the left hypochondriac region, while the gallbladder, that is located just below the liver, is located on the right hypochondriac region. Again, the two kidneys, that is both the right and the left kidneys, they are all located in the virtually upper part of the abdominal cavity. There are other important structures or intra-abdominal structures that we will discuss when I come along with the other aspect of the clinical anatomy of the abdomen. I will discuss them. So now, if you ask the patient, to lie down on the examination couch, you make inspections of the abdomen. And so, what are the things that you're supposed to see when you ask the patient to lie down on the couch or on the examination bed? So first and foremost, you may likely see some scars on the abdominal cavity. Scarification is part of the, certain, traditional, activities or traditional kind of, identification of, certain tribes or ethnicity in certain countries, especially in African countries, whereby you see certain, tribes or tribal, communities. They tend to make some scars on the anterior abdominal wall or even on the chest. So these scars are mainly, certain marks they are made on the abdomen or on the chest for one to be able to, for the certain ethnicity or tribe to identify their own family members or tribe members. Apart from seeing scarification marks mainly for identification and what have you, other scars may be as a result of maybe surgery or maybe as a result of trauma that has happened, affecting the anterior abdominal wall. So one may likely see a scar just by mere inspecting the abdomen, and again, wound, either fresh wound or old wound can also be seen on the abdomen when you are inspecting the anterior abdominal wall. So this wound may be small or may be large, and may be fresh or may be, very long ago, on the abdomen. And you may also see discoloration. That means if somebody is a light-skinned individual, you may see some patchy areas along the abdomen. Even among the dark in complexion individuals, one may likely see certain, discoloration, whitish or light in complexion discoloration on the dark skin of an individual. So these are what we call skin discoloration, whether on a light skinned individual or on a dark skinned individual. Again, one may also see swellings. These swellings may be seen on the abdomen, on the anterior abdominal wall and abdominal wall. So these swellings may be as a result of hernia. And as you are all aware, that hernia is just protrusion of something from the interior aspect of the abdomen. So it may protrude into the anterior abdominal wall, and so this is what we call hernia. So hernia can be defined as protrusion of something into something through something. So now this swelling, as I said, we call it hernia, and maybe any part of the intra-abdominal content, something like this, the smaller intestine, or maybe something like a portion of the stomach, or any part of the intra-abdominal content may herniate or may protrude into the anterior abdominal wall. And these protrusions into the anterior abdominal wall, is possible only when the anterior abdominal wall muscles are weak as a result of old age or as a result of, trauma or surgery, if somebody went, or underwent a surgical procedures that can affect the integrity of the abdominal muscles, and so that can make the abdominal wall muscles weaker. And so this hernia can now take place. So there are various hernias that can happen or they come out of the anterior abdominal wall, something like, epigastric hernia. That means protrusion of the intra-abdominal content in the epigastric region. So it is located in the midline. Similarly, umbilicus the hernia can occur around the umbilicus. So that is what we call umbilical hernia. Again, the hernia can also, the intra-abdominal content can come out of the inguinal canal, and that is what we call inguinal hernia. Or the intra-abdominal content can also pass through the femoral, sheath or through the femoral canal, and so the content can protrude in the groin, and that is what we call femoral hernia. So there are various hernia that can happen on the abdominal wall, and so by mere inspections, one can see this, swellings, hernias on the abdominal wall. Again, one can see, a protruded abdomen, either in young individuals or in old people. So, or in any age group. So, if you see this abdominal swelling, even as a woman, first thing that may come into your mind, maybe that woman is pregnant. And so, there are various ways that by which somebody can now, exclude pregnancy in a woman with this abdominal swelling. Maybe by asking her certain questions like, when last did you see your last menstrual period, or if it is a woman of reproductive age. You can also ask her whether she's married or not, or if she's not married, so you can, that does not exclude pregnancy still, because there are certain people that are not married and yet they can get pregnant if it's happened that that woman or girl had a sexual intercourse with somebody out of marital status. But there are certain conditions that can make this abdomen protuberant, like what a condition that we call ascites. That means accumulation of serous fluid in the abdominal cavity. And so this happens as a result of so many conditions within the abdomen, maybe like liver diseases, heart diseases, and other diseases or conditions that can affect the abdominal organs. Again, you may also see some protruded veins. You can see some of the veins of the anterior abdominal walls, they tend to be prominent, and so that one too can be seen by mere inspection of the abdomen. So the next thing that one can do is to also see where the location of these dilated veins are in the anterior abdominal wall. For example, now around the umbilicus, one may see that the veins around that side, they get enlarged. And that is what we call caput medusae. And so these dilated veins now, they radiate away from the umbilical region. And so because they radiate, that is why they are known as called, caput medusae. And so this is as a result of, compression of the portal vein that carries the oxygenated blood plus the oxygenated blood into the liver. So if there is a liver condition, something like liver cirrhosis, if the portal vein is being compressed by the cirrhotic liver, that can cause this caput medusae, that is dilatation and radiation of the para-umbilical veins away from the umbilicus. That is caput medusae. Again, one can see what we call omphalocele, and that is a hernia, of the umbilicus when a baby is born. And this type of umbilical hernia is not covered by skin, but rather is only covered by a peritoneal membrane, and that is why it is called omphalocele. But if that kind of hernia is covered by skin, that is what we call umbilical hernia. All these conditions can be seen by my inspection of the abdomen. So that is, inspection of the abdomen, the anterior abdominal wall. So the next thing that one can do in the clinic, when the patient is lying down, you can also palpate the abdomen. You are all aware that anatomically, the abdomen is being divided into 4 quadrants: upper right quadrant and upper left quadrant, then lower right quadrant, and then lower left quadrant. Similarly, the abdomen can also be, in certain books, students may come across that this kind of the abdominal cavity is also being divided into 9 regions. So whichever way you take it, if you want to palpate the abdomen, you can palpate it either quadrant by quadrant, or you palpate it region by region. So the reasons for palpating the abdomen is to find out whether the intra-abdominal organs are enlarged, something like the kidney. If it's enlarged, one can palpate it using the palpation method. Similarly, liver, the spleen or the pancreas or any of the intra-abdominal contents can get enlarged. So through palpation, one can ascertain whether any of the intra-abdominal organs are enlarged. And so this is just the way one is going to palpate, or the method of palpating the anterior abdominal wall as well as the intra-abdominal content. The next procedure is percussion. So percussion is just like trying to find out whether the swelling you find in the abdomen, it is hard or soft or fluctuant. So by percussing, one can determine what is the nature of the swelling inside the abdominal cavity. So if it is an enlarged organ that is very hard, so when you percuss, the kind of sound one is going to hear is different from the kind of sound one is going to hear if that swelling is only firm to touch, not hard. Similarly, if it is only liquid that is located, the swelling of the abdomen is containing liquid there, or blood or anything, the percussion knot is also going to be different from the percussion knot if that swelling inside the abdomen is hard or firm to touch. The same thing if it is ordinary air, the percussion knot is also going to be totally different from this thing that I have discussed. Again, you can auscultate the abdomen by using the stethoscope. The stethoscope actually is an instrument that doctors use in the clinic to hear or listen to the intra-abdominal sounds, the intra-abdominal, intra-abdominal content, especially the smaller intestine. The intestine contains air, and so there is what we call bowel sound. So the bowel sound can be listened by using this stethoscope, and so there is normal bowel sound that one can hear. So if that normal sound is tempered by maybe certain diseases affecting the small intestine, or maybe certain condition affecting the small intestine or large intestine, obviously by the time one listens to this bowel sound, the bowel sound knot is going to be totally different or away from the normal bowel sound. So these are the 4 things that one can do, in the clinic. When somebody comes to that doctor, the clinic, you ask the patient to lie down, so you inspect, and then you palpate, then you percuss, and finally you auscultate. So through these 4 means of examining the patient while the patient is lying down, so many things or so many diseases or conditions, can be, assessed by using these 4, ways in the clinic. Again, you can also do certain procedures in the clinic. For example, now if you are sure that the peritoneal cavity of the abdomen is being infected, so one can also try to remove the pus accumulation, or if it is a fluid accumulation as a result of the ascites that I've discussed, whereby there is accumulation of the serous fluid inside the abdomen. So one can try to tap, the acidic fluid out of the abdomen, or if it is a pus that is accumulated inside the abdominal cavity, one can also withdraw the pus or withdraw the fluid, or if it is a blood, so one can try to withdraw the fluid so as for the person to be able to, feel a little bit better. Because once there is accumulation of fluid or intra-abdominal, enlargement of any organ there, so the person with such clinical conditions may have difficulty in breathing, because once there is an enlargement in the abdomen, there is likely going to be an increase in intra-abdominal pressure, and that may likely that is going to have definitely an effect in the thoracic cavity, and so the patient may find it difficult to breathe in and out, air. And so, during breathing, one would breathe in oxygen, the diaphragm now descends down. So if there is an intra-abdominal enlargement, the descending down of the diaphragm is surely going to be affected. And so that will definitely interfere with the, breathing exercise of that person with that kind of condition. So again, you can also, make certain procedures on the abdomen, like if you want to cut across, the anterior abdominal wall, especially during surgery, if you want to remove anything out of the abdomen, so you can, cut along the skin and then try and separate the fibers of the muscles of the abdomen. And so these are all clinical procedures, and at times one can even try to, make some, withdrawal of fluid out of the abdomen. All these are certain minor procedures that one can do in the clinic. So if you want to make a surgery, there is what we call natural lines of cleavage. These natural lines of cleavage, they are naturally there along the skin of an individual. So by using these natural lines of cleavage, actually one is going to, make sure that these natural lines of cleavage, if as a surgeon you want to make an incision, you have to follow along the orientation of the lines of cleavage. By following the natural lines of cleavage, what you call the Langer's lines, So this, if a surgeon wants to make a cut across the abdomen, he or she has to follow these natural lines of cleavage for that person to have a cosmetic kind of scar after healing. Otherwise, if as a surgeon you don't follow these natural lines of cleavage during surgery, you are likely going to leave a very huge disconfiguration of the anterior abdominal wall of that person, because it is going to leave a very large and disfigured scar along that line. So that is why actually it is mostly advisable, or always advisable, if one is going to make an operation or cut across any part of the human body during surgery, it's advisably supposed to be cut across the natural lines of cleavage. So you can see these natural lines of cleavage on the anterior abdominal wall. They pass downward and towards the midline, and that is exactly the surgical incisions are supposed to be made. Although actually these natural lines of cleavage have been tampered by surgeons, maybe for one reason or another, which we'll see. This, if you now look at this slide, now this slide is just showing us, the different categories of, cutting or incisions that has been made on the anterior abdominal wall. So these incisions actually are done, if someone wants to do surgery, and the incisions that a surgeon is going to make, on the anterior abdominal wall depends on the nature of the disease or conditions affecting the abdomen. For example, if it is liver that is being affected, or the gallbladder, and it is being confirmed that it is, either of the two, either liver or gallbladder, so this kind of incision, is advisable, because this is just the area where the location of the gallbladder is, as well as the right lobe of the liver. So if the right lobe of the liver and the gallbladder are affected, this first incision is the most appropriate, and that is what we call subcostal incision or Kochas incision. So this subcostal incision is an incision that is being done actually parallel to the costal margin, the right costal margin. So again, if you want to make an operation that involves, examining any organ within the abdomen, that means you are going to explore the abdominal cavity. This is what we call exploratory laparotomy. This exploratory laparotomy, this incision is being done along the midline. That means incision done along the linea alba. Linea alba is a midline, incision of the rectus abdominis muscle. So in the midline there, the tendons of these two muscles now is located there. And it is happened to be that this area of tendinous union of these two muscles of the abdomen is avascular. That means it's devoid of blood supply. So that is why actually most of the surgeons, they find it comfortable to cut across this midline, across the linea alba, so that the bleeding is going to be minimal. So you can open up the abdomen along this midline incision, and then you can explore the abdomen. You can also do this midline incision in the upper part of the abdomen. That is what we call upper midline incision. Or you can also do a lower midline incision if you want to open up, intra-abdominal content that are at the lower level of the abdomen. So the choice of this incision of the midline, whether upper or lower parts, so it depends on where you want to explore within the abdomen. So this second incision is what we call, midline incision. There may be a situation whereby this midline incision can be started right from the xiphoid process down to the pubic symphysis. That is, if somebody wants to expose the whole abdomen to be able to have access to all the intra-abdominal organs. So this extensive midline incision can be done in trying to explore everything that is located within the abdomen. So the third incision here is what we call the gridiron incision. This gridiron incision is along the McBurney's point. McBurney's point actually is a landmark, a point that is lying, between the umbilical, region down to the anterior superior iliac spine here. So upper two-thirds of this line, joining the umbilical to the anterior superior index spine, this upper two-thirds here, the junction between the upper two-thirds and the lower one-third of the line, this is where one can place his own incision. And this kind of incision is only done when somebody has an acute or chronic appendicitis, and this is what we call gridiron incision. It is mostly done when somebody wants to do an appendectomy as a result of appendicitis. Again, there is what we call button incision. This button incision is just a paramedian incision. This paramedian incision is done on the lower part of the abdomen, just away from the midline, and this is what we call buttress incision. And this one too can also be done in patient that has appendicitis. Again, this lance incision, a transverse incision that is most appropriate if somebody wants to do an appendectomy. This lance incision is done along the longest line, that is lined transversely or obliquely across the anterior abdominal wall, passing downward and towards the midline. And this lance incision is better than this gridiron incision and the button incision, because this lance incision is most likely not going to leave a disfigured scar after the surgery, after healing process. And that is why most of the surgeons, they prefer to do this lance incision, because it is located along the longest line or along the natural lines of cleavage. So we have three important, surgical incision with regard to appendectomy, or when somebody has appendicitis. So one can either do a gridiron incision, or one can do a modified gridiron incision, and that is what we call lance incision. And the other one, is what we call the buttress incision. The other incision is what we call the Phalansteal incision. This Phalansteal incision is done when somebody is going to do a cesarean section. Cesarean section is when a woman cannot deliver by herself, and so the obstetrician can now operate that woman by making an incision just above the suprapubic region. And so this incision is along, is made transversely across the pubic region, and that is what we call Phalansteal incision. So it's mainly done in delivering a baby from a woman that cannot deliver by herself. The other incision that can also be done, this is incision, what we call Rutherford Morrison incision. This Rutherford Morrison incision is done if somebody wants to explore either the descending colon or the ascending colon on the right side. So you can do this Rutherford Morrison incision either on the left hand side or on the right hand side. This is mainly done in trying to expose the colons, either the ascending colon or the descending colon, or the sigmoid and the rectum along the left hand side. Also, if somebody wants to expose certain structures like the common iliac arteries or common iliac veins, so one can get access to these structures by using this Rutherford Morrison incision. Again, there is also another incision that can be done, and this is the seventh incision here, what we call a transverse incision that is done across the transverse, part of the abdomen, and you can see that it extends from the right side down to the left side. And so this one too can also be done if someone wants to expose, like kidneys, both the left and the right kidneys, or maybe the transverse colon, or the duodenum, the pylorus, and other structures that are around the midline, midline aspect of the abdominal cavity. Again, the paramedian incision, that can also be done on either side of the anterior abdominal wall. And this one too can also be done if you want to explore, like if you do it on the left hand side, if you want to explore, if you want to make a surgery of the spleen or pancreas, so you can do this paramedian incision. Again, you can also do the same incision here, the paramedian incision, if you want to operate on the stomach or on the spleen, or on the pancreas. So this paramedian incision can be done on so many intra-abdominal conditions or diseases. So, but these are the common incisions that are done in the surgical departments, or that are done by a surgeon. Again, one can do certain procedures in the clinic. For example, if we want to, make an intra-abdominal, dialysis. If somebody wants to do what you call peritoneal dialysis, so peritoneal dialysis can also be done as a procedure, in the clinic or in the ward. So these are part of the processes, that one can do in the clinic or in the theater or in the ward even. So this can be done. Again, there are certain conditions that affect the intra-abdominal structures, like the trauma. That means when we talk about the trauma in medicine, we're talking about the either domestic accident or road traffic accident. Domestic accident includes the knife injuries, gunshot injuries, or any sharp object injury at home, or road traffic accident where somebody is inside a moving vehicle, and then that vehicle somersaults, and the vehicle now injured the intra-abdominal organs or structures. So any of the intra-abdominal organs can get ruptured or can get affected as a result of that trauma or as a result of that accident. Supplementing the liver, the stomach, the kidneys, any of them can get affected as a result of that trauma, either domestic trauma or road traffic accident. Again, infections, any of the organs in the abdomen can get infected. Like if the liver is infected, that is what we call hepatitis. Hepatitis can happen as a result of either viral disease, what we call viral hepatitis, which is divided into hepatitis A, B, C, D, and E, and also the hepatitis can result as a result of, bacterial infections, or maybe it is as a result of protozoa, something like the amoebiasis. I'm sure some of you may come across the protozoans known as amoeba. So that amoeba can also affect the liver so as to cause hepatitis. So any of the organs in the abdomen can get infected, like the pancreas, pancreatitis. Pancreas can get infected, and even the kidney can also get infected. So once the kidney is infected, that is what we also call nephritis. And if the stomach is infected, that is what we call gastritis. So any of these intra-abdominal organs can get infected. And so the intra-abdominal organs can also have, swellings. And that swelling can be either a benign swelling or a malignant swelling. What we mean by benign swelling, that means swelling that is not cancerous. So a malignant swelling, we are talking about cancer of any of the part of the body. And if it is in the abdomen, liver can get cancerous, pancreas can get affected by cancer, the kidney, the stomach, the large intestine, the rectum, and so on and so forth. All of them can get affected by cancer. And finally, congenital anomalies can affect any part of the intra-abdominal structures. Now let me just take any of these organs in the abdomen one by one for me to be able to discuss certain clinical conditions that can affect such organ. If, for example, now I take the stomach can get affected by all those conditions that I have highlighted in the previous slide. That means the stomach can get infected to cause what you call gastritis. And so this gastritis, is as a result of infection either from the microorganisms, either bacteria or virus. Most of the common organisms that affect the stomach is, as a result of, bacterial infection, like the Salmonella typhi, typhoid fever that is been common in our own environment. So typhoid fever can affect the stomach to cause this gastritis. Apart from that, other commoner organisms like the Helicobacter pylori, the microorganism that causes peptic ulcer disease, that can also affect the stomach. And so if it affects the stomach, that can cause ulceration of the stomach and cause what we call peptic ulcer disease or gastric ulcer. Again, the stomach can get affected by cancer. So cancer of the stomach is very common also in our locality. Again, trauma, either domestic trauma, maybe through fight between partners, either husband and wife or two women, in a polygamous family. Fight between two women in our own country is very common, and so it can be either as a result of knife injury, where one of the partners now carries knife or any sharp object to injure his own opponent. So the stomach can get also torn as a result of that domestic trauma, or maybe road traffic accident or gunshot or anything like that. So by so doing now, the stomach can get ruptured, or maybe the rupture may be very wide rupture, or maybe just a small hole as a result of maybe gunshot injury or knife injury. By so doing, if that happens now, actually, that person with such kind of trauma of the stomach must be sutured by the surgeon. Congenital abnormalities can also affect the stomach. So hernia also can affect the stomach. Congenital hernia, that is what we call the sliding hernia. When the part of the stomach herniates through the esophageal hiatus. I'm sure you can remember your anatomy vividly, because in the diaphragm there are three important openings. These openings include the opening for the esophagus, and this is the opening through which this part of the stomach gets herniated through that esophageal hiatus, and then it causes what we call sliding hernia or paraesophageal hernia. And so if this happens now, the person must undergo operation to push back that portion of the stomach that herniates into the thoracic cavity. It is going to be pushed back into the abdominal cavity. And this is one of the congenital anomalies affecting the stomach. I've already discussed about the gastric ulcer that can affect, the stomach. And again, peptic ulcer, I discussed about it. Peptic ulcer is the same as the gastric ulcer. And so if somebody has ulcer of the stomach, or ulcer of the duodenum, there are certain surgical procedures that one can do to allow that person to have relief as a result of that ulcer. As we are all aware that the mechanism of the ulcer is as a result of this Helicobacter pylori that ulcerates the mucosal lining of the stomach, and then the acid that is being secreted by the cells of the mucosal lining of the stomach, all this hydrochloric acid, that one too continues to ulcerate the already ulcerated area. And so if a patient has been taking medications for quite a while and there is no relief, that person can get better relief by doing a surgical procedure, what we call vagotomy. So we are all aware that the stomach is being supplied by the vagus nerve. The vagus nerve, is the 10th cranial nerve, and it is the longest cranial nerve in the human body, and it is the nerve that supplies the gastrointestinal tract. So when that nerve comes towards the esophagus, that nerve divides into two, anterior branch and posterior branch. So one has to cut the anterior branch and the posterior branch of the vagus nerve. By so doing, the supply of this vagus nerve to the stomach is being cut off. And so the secretion of the hydrochloric acid by the stomach, which is under the influence of these branches of the vagus nerve, is no longer there. That is what we call total vagotomy. And so if this total vagotomy actually has its own complications. So if you don't want too much complications, you can also do what we call selective vagotomy. If it is only the anterior wall of the stomach that is having the ulcer, so you can do anterior vagotomy. If it is the posterior wall of the stomach that is being affected by that ulcer, since the posterior division of the vagus nerve supply the posterior part of the stomach, so you can do posterior vagotomy. That is what you call selective vagotomy. Again, if you specifically find out the area of the ulcer on the stomach, you can also do a highly selective vagotomy, whereby that surgeon now cuts specifically the nerve supply of the area where the ulcer is located. That is what we call highly selective vagotomy. If a surgeon does this kind of operation, the person will surely feel relief. Part of the conditions that affect the pancreas include infection, where somebody can have pancreatitis as a result of either typhoid disease, or maybe as a result of tuberculosis, or as a result of any other kind of microorganism. Similarly, cancer of the pancreas is common in certain countries, but in our own environment, pancreatic ulcer is not all that common in our own locality. But when someone goes abroad, pancreatic cancer is a little bit common. Trauma also, like gunshot, knife injury, can also affect the pancreas. And so, actually pancreas is being supplied by the pancreatic artery, which is a branch of the celiac trunk. And so, injury to the pancreas actually can lead somebody to bleed to death. And so, trauma of the pancreas is very, very dangerous, because the pancreatic artery actually, it comes from the abdominal aorta directly from the celiac trunk, and it comes with a very high pressure. And so, bleeding of the pancreatic artery, that can cost someone his life. And again, congenital abnormalities, whereby somebody has, abnormal pancreas, congenital anomalies can affect, the pancreas, where the pancreas is abnormal, or it may completely be absence of the pancreas. And pancreas actually is very, very important to our life, because it secretes three important hormones: the glucagon, responsible for the metabolism of the glucose, and the insulin, as well as the somatostatin. All of them, they are also important in our own, glucose metabolism and what have you. So this is just a slide showing, pancreatic tumor along the ventral surface of the pancreas. This is just the pancreatic tumor, and this is the duodenum, and this is just open part of the duodenum showing duodenal ulcer, due to the high amount of acid coming from the stomach. And so, high amount of acid coming from the stomach from Zellweger-Ellison tumor or syndrome, this increase in acid can now cause ulceration of the duodenum, and so it can cause this duodenal ulcer. So now, what are the conditions affecting the intestine? The intestine, the small intestine or large intestine, any of this can get infected by either bacteria or virus or protozoans like the amoebiasis and what have you. All those ones can affect the intestine. Similarly, cancer, chronic cancer, can affect the large intestine, and also trauma like gunshot, knife injuries, and any other injury can affect the intestine, either large or small. Congenital abnormalities can also affect the small intestine. So now, other, when the small intestine or the large intestine is affected, the area of involvement can get excised, and then what we call end-to-end anastomosis between, the two cut ends can be joined together, by the surgeon. That is what we call end-to-end anastomosis. That means you cut the area of the disease, and then you join the two areas that are healthy, and that is what we call end-to-end anastomosis. Or if it is a large intestine, if the lower part of the large intestine is being completely blocked, one can do what we call colostomy. That means you bring the large intestine opening. When you cut, across the length of the large intestine, you suture the distal end, and then you bring the proximal end of the cut end of the colon. You create an opening across the anterior abdominal wall, and then you leave it there permanently. And that is what we call colostomy. And that colostomy can be done as a result of so many conditions affecting the colon. Again, appendicitis. Appendix, is a finger-like projection across the terminal end of the ileum. And this appendix actually, once it is being inflamed, that is what we call appendicitis. And this appendicitis, is a kind of inflammation of the appendix, and can be as a result of either deposited fecal matter in the appendix, or maybe as a result of bacterial infection or fecolith, or any other organism. So once the appendix is inflamed, it is advisably supposed to be cut, and so the surgery is what we call appendectomy. And so I've already discussed the different categories of surgical incisions that one can do to remove this an inflamed appendix. So what are the conditions that affect the liver? So liver can get infected by, the virus, what we call the viral hepatitis. So these viruses include hepatitis A virus, hepatitis B, C, D, and E. Any of this kind of virus, can affect the liver and cause what we call hepatitis. Similarly, cancer of the liver is very common in our environment, especially among those who are alcoholics or those who tend to smoke cigarettes, seriously. And so cancer of the liver is very common among these two categories of individuals. Even among other people, cancer of the liver is possible, but then it is higher, or the prevalence is higher, or the incidence is higher among people who tend to drink too much alcohol or cigarette. Again, trauma of the liver due to the domestic injury or road traffic accident. Congenital anomalies can also affect, liver. Again, liver cirrhosis can happen, and if that happens, actually, liver can compress the, the portal vein, which will now cause what we call portal hypertension. So if you now look at this liver here, you are going to see that this liver is fresh, and it has a smooth surface. It is reddish brown in color, and it is of normal size. So when you compare this with the cirrhotic liver, the liver cirrhosis, the liver that is cirrhotic, you are going to see that the surface of that liver is not smooth. So it is rough because of these nodules. So the surface there is it is an irregular surfaces because it has these nodules, and the liver may likely be enlarged or may be shrinking. So any of this, can happen in person with liver cirrhosis, and patient with this liver cirrhosis will likely have a compressed portal vein that will finally lead to portal hypertension, and that may finally lead to caput medusae that I have discussed initially. So this is just a slide trying to show, the portal vein formation and how it causes, how it is likely going to cause the caput medusae. This is just a slide showing the dead liver cells. This is a liver cancer. So the liver cells, the hepatocytes around this area, they are all destroyed by the cancerous cells of the liver. And so this is just damaged liver cells, and the normal ones here, they continue to be eaten up by these damaged liver cells. And so the liver damage continues across the parenchyma of this liver. And so this is cancerous liver tissue. So part of the procedure that one can do in the clinic, in the abdomen is what we call colonoscopy. This colonoscopy is done, when somebody has a blocked, gastrointestinal pathway, when somebody could not pass feces with ease. For example, somebody that has a rectal tumor or rectal prolapse or rectal polyps or foreign body in the rectum. All this can block the rectum or the sigmoid colon. So the surgeon can now use this colonoscope to inspect the sigmoid colon or the rectum or the descending colon for the surgeon to be able to locate the area of the swelling or the blockage, so as for that surgeon to be able to make a recommendation to the surgeon that is going to operate that person. So this is a colonoscope, and so the procedure that is being done in the clinic to ascertain the area of blockage in the lower part of the gastrointestinal tract, that is what we call colonoscope. Conditions affecting the urinary system. Urinary system, involves the two kidneys, the two ureters, and then the urinary bladder. So infection can affect the kidney, and so if that happens, that is what we call nephritis. That means infection of the kidney. So not only involving the entire kidney, the glomerulus or the glomeruli of the kidney can also get infected by staphylococcus or any other bacterial infection, and that is what we call glomerulonephritis. And so, apart from this involvement of the glomeruli or the entire kidney itself, the kidney, we are all aware that is responsible for sieving out our toxic waste from the blood. And so, if the liver is being, its own function is being impaired, so part of this toxic waste, may not be able to pass out of the kidney, and so they may likely sediment there in the kidney and cause what we call renal stone or what we call kidney stone. Similarly, the kidney stone, can get trapped along the ureter. This is just a pipe that collects the urine from the kidney, and so by collecting the urine from the kidney, this ureter, the urine from the ureter is going to be passed into the bladder, and so the bladder serves as a storage area for the urine. Apart from the infection of the kidney, the kidney itself can also be affected by congenital by trauma. That means gunshot. So somebody can get shot, by gun into the kidney, but thereby shattering either one or both the two kidneys. Similarly, knife injury can affect, the two kidneys or one kidney. For example, during endeavor fight in our own environment, somebody can get his own kidney injured when a knife is being used to prick that person from the posterior abdominal wall at the back, upper part of the back of the posterior abdominal wall. And so that is going directly into the kidney. So kidney can get traumatic as a result of either domestic accident or road traffic accident, or during fight, or as a result of gunshot. Again, congenital abnormalities can also affect the kidney, what we call the polycystic kidney, or maybe the horseshoe kidney. All these are congenital abnormalities that can affect the kidney. Again, there may be ureteric stone. This is ureter, and so the ureter can have stones. When we talk about the kidney stone or ureteric stone, we're talking about the accumulation of the salt, that are being excreted by the kidney out of the blood in our own body. And so those salts that are being excreted by the kidney, at times they get sedimented and form solid, materials that can get lodged either within the kidney or within the ureter. So this is just the horseshoe kidney. Initially during intrauterine life, the two kidneys they tend to develop within the pelvic cavity, and so the two kidneys may get united across the two poles, the lower poles of the two kidneys, and so it forms this horseshoe-shaped, kidneys, and so the kidneys cannot ascend up to go into because they have been trapped by this inferior mesenteric artery, and so the kidney is now ectopic, and this is what we call horseshoe kidney, which is an example of an ectopic kidney. This is just like the polycystic kidney that I made mention before. So you can see that along the contour of the kidney, you will see that there are some cystic areas of the kidney now, getting cystic, and this cysts contain fluid or urine, and they are multiple, and this is what we call multicystic or polycystic kidney. Conditions, can also affect, there are conditions or diseases that can affect the lumbar bones, lumbar vertebral bones, because these lumbar vertebral bones are responsible for making the framework for our abdominal cavity. It is through these lumbar bones, all these our posterior abdominal muscles, they take origin, or some of them they even insert in there. And so the bones, the lumbar bones, they can get infected by tuberculosis. Pulmonary TB can also, because the pulmonary TB is caused by the the Mycobacterium tuberculosis, and that Mycobacterium tuberculosis can also affect any bone in the human body, and that can also affect the lumbar bones. And so if that happens, it can cause what we call Psoas abscess. So apart from forming the Psoas abscess as a result of this infection as a result of this Mycobacterium tuberculosis, cancer of the lumbar bones can happen, like osteosarcoma of the lumbar bones, lumbar vertebrae, or trauma as a result of the road traffic accident, or congenital abnormalities can also affect the lumbar bones. This is just a slide showing the Psoas abscess. So this is the part of the bones, the lumbar bones, affecting the Mycobacterium tuberculosis affecting the lumbar bones, and so this is a pus accumulating, deep to the psoas fascia, the fascia covering the, psoas major muscle, and so the psoas abscess now gravitates through or deep to the inguinal ligament and come into the groin, and one may likely confuse this psoas abscess with the inguinal, hernia. So this is just a slide showing the referred pain. When you hear this word referred pain, it is talking about a pain originating from somewhere, but it's being referred to other places far away from the area of its origin, or far away from the primary area of origin. For example, now somebody may have a cholecystitis, that means inflammation of the gallbladder, and so if that happens, actually pain may be referred down to the right shoulder, and this is as a result of sharing of the nerve supply between the parietal peritoneum covering the undersurface of the diaphragm with the shoulder. The parietal peritoneum of the undersurface of the diaphragm on the right side is being supplied by the phrenic nerve. I know that the root value for the phrenic nerve is C3, C4. So this area above the shoulder is being supplied by C3, C4, and so pain as a result of the cholecystitis, inflammation of the gallbladder, that pain may be referred down to